The topic of women's health is often poorly covered not only by mainstream media but also by research as well. But on this podcast, we've done a ton of episodes where we deep dive into women's health. But in this episode, we're going to go a little bit deeper. This is the Dr. Karan Explores podcast, and I'm Dr. Karan. So let's get into it. It seems that for decades, well, centuries probably, medicine treated women as if they were just smaller versions of men, and historically, doctors considered the male body the norm and the female body as the atypical variant. The result was that women were grossly underrepresented in medical research and in clinical trials. Even in animal studies, researchers often avoided female mice due to confounding hormone cycles.
Historically, it didn't interest the people who were in charge of medicine, or if it did, it didn't interest them very much. You also have to understand that hormones weren't discovered until, the early 1900s. So I think, it's a combination of misogyny and not having women in medicine to be representative to say, well, hey, you know what? I think that might be like an important subject.
The fallout of this bias was pretty serious because drugs and treatments were designed for male physiology and then simply extrapolated to women, and sometimes with harmful effects. For example, women can experience adverse drug reactions at twice the rate of men, so it's important that we look at drugs and other medicinal therapies in women in trials as well. And if you look at a lot of these studies, the dosing and safety profiles weren't properly calibrated to female biology. Key aspects of female biology, menstrual cycles, pregnancy, menopause have been understudied and poorly taught. In fact, many women are never educated about their own hormonal rhythms. In fact, nearly half of women, around 48.9%, say they do not have a proper understanding of the menstrual cycle. Less than 2/3 know how many phases the cycle has, and almost 90% feel their healthcare provider pays insufficient attention to their cycles. This knowledge gap leaves women in the dark about what normal really means for them, and to be honest, there is no normal cycle, there's just your normal. Every woman's hormonal profile is unique, and empowering women starts with recognizing that. Now, it's worth appreciating that hormones aren't just about reproduction. They are a whole body communication network. Estrogen and progesterone, often mislabeled as just sex hormones, have receptors virtually everywhere. The brain, the heart, the blood vessels, bones, muscles, the gut, skin, you name it. Estrogen, for example, helps regulate the brain's energy usage and neurotransmitters, influencing mood and cognition. It keeps the blood vessels flexible, strengthens bones, and even affects the microbiome in our gut. And we've spoken on previous episodes a lot about the crossover between the microbiome and women's health conditions.
Gut health and hormone health are intricately connected. There's more and more research coming out about how different types of bacteria in our gut, in our microbiome, can influence things like our weight, our mood, how our hormones are functioning. So we do work inside of the microbiome. We help to eliminate some of those, opportunistic pathogens and opportunistic bacteria. And we work to replenish the gut with healthy, normal commensal bacteria. And it can make a huge difference.
In other words, women's hormones influence almost every organ system, not just the uterus or ovaries. So when women experience brain fog, joint aches, palpitations, or digestive changes at different hormonal phases, it's not all in their head, it's biology. Now, there is some good news in all of this, is that we're finally seeing a revolution in understanding female biology, and it starts with listening to women and studying women, obviously. Now, everybody, especially on the internet, seems to want quick fixes for hormone imbalance, and you'll see people pushing hormone testing kits or magic supplements to balance your hormones. But here's the truth from actual endocrinologists that I've spoken to. Hormones are dynamic. They fluctuate hour to hour, day to day, by design. Hormones oscillate and they're dynamic, and they will go up and down depending on your body's needs. In a healthy cycle, hormone levels aren't static at all. For instance, estrogen and progesterone rise and fall in a complex symphony each month, and cortisol surges in the morning and dips at night. Insulin spikes with your meals, etc. If our hormone levels didn't constantly change, we'd quite literally be dead, or at least not functioning. This means a single hormone test, like a one-time blood draw, offers limited insight. And that context is everything. An example would be if a woman randomly measures progesterone and it comes back low, it might simply be the wrong phase of her cycle, because progesterone is naturally low in the follicular phase and only high after ovulation. Without context, one could falsely think that there's a deficiency. I've often seen patients that are worried about certain lab tests that they've had online, and they've not realized that it's appropriate to have low progesterone, for example, at a certain time of cycle. In general, for a cycling premenopausal women, hormone levels are meant to change. There is a range of normal. Moreover, hormones respond to countless factors in real time: stress, sleep, nutrition, exercise, medications, the weather, you name it. Take stress, for example. A spike in the stress hormones, cortisol, adrenaline, can in turn disrupt the delicate balance of reproductive hormones. High cortisol can blunt or delay ovulation and throw off menstrual timing. Chronic stress can literally interfere with the brain-ovary signal. In evolutionary terms, it makes sense because in times of extreme stress or danger, the body might shut down fertility temporarily. But in modern life, many women live in a state of chronic high stress, so these dynamic hormone adjustments can become chronic issues like irregular cycles or low progesterone states. The bottom line is that interpreting hormones isn't like checking the oil in a car, it's more like forecasting the weather. A single snapshot can mislead you if taken out of context. The best clinicians will look at patterns, for example, tracking levels across a cycle or assessing symptoms over time rather than just one-off numbers. And often the first steps to fix hormones are holistic. It's reducing stress, improving sleep, adjusting diet and exercise, not simply popping a pill. Whilst hormone tests and treatments are invaluable tools, especially if you have a true endocrine disorder, they must be used with nuance. So don't be duped by anyone claiming to balance your hormones with a single test or a single supplement, because our hormone networks are far too dynamic for a one-size-fits-all solution. Now, on this same topic of women's health, it's important to pivot to a topic that highlights how women's health information is often incomplete, and that's the topic of birth control. Contraception has been a game changer for women's autonomy, no question. But many women aren't fully informed of how hormonal contraceptive work under the hood and what long-term effects can be. And this isn't a spiel about pills are bad or pills are good, it's about informed choice. Now, most birth control pills are a combination of synthetic estrogen and progestin. They prevent pregnancy largely by suppressing ovulation, essentially tricking the brain into thinking you're already pregnant or not needing to ovulate. They do this by stopping the usual hormonal signals, FSH and LH surges, that makes the egg mature and release. With no eggs released, pregnancy can't occur. Progestin also thickens cervical mucus, thus blocking sperm, and it also thins the uterine lining. There are certain options which are progesterone-only methods, options like the mini pill, the progestin-only pill, the Depo-Provera injection, or some IUDs like the Mirena coil rely on progestin without estrogen. These often do allow some degree of ovulation in many cycles, but not always. For instance, around 40% of women on these mini pills still ovulate. On the other hand, Depo-Provera, which is an injection, strongly suppresses ovulation in most users. And a key point, if ovulation is suppressed, the body's natural estrogen production from the ovaries is also lower. Some women on long-term progestin-only methods therefore have chronically low estrogen levels, which can have side effects like lower bone density over time. And the FDA even has a warning about Depo-Provera and bone loss for this reason. Doctors often still recommend these methods because of the benefits, reliable contraception, and in Depo's case, it can help conditions like endometriosis. And that may outweigh the risks, but women deserve to know some of the trade-offs as well. Now, if you've ever wondered why most pill packs have a week of placebo or sugar pills causing a withdrawal bleed, then there's something interesting from a historical perspective and some evolving thinking around that as well. Originally, the pill's inventors included a monthly bleed to mimic a natural cycle, partly to reassure women they weren't pregnant, and even, legend has it, to make the pill more acceptable to the Catholic Church by seeming natural. Medically, that withdrawal bleed isn't necessary for health, but some newer regimes eliminate periods for months. But continuously suppressing the brain-ovary signaling without any break might have subtle effects on things like mood or libido for some women. Some physicians speculate that giving the brain a short break, the placebo week for example, allows a brief reset of the GnRH pulse generator, the hormone signals in the brain, though that evidence is a little bit anecdotal. In practice, continuous pill use is considered safe for most women and can reduce headaches or other period-related issues. Whether to take a break is a personal choice and something to discuss with a knowledgeable doctor. I think the key takeaway here is that there's no universal right way. Some do better with a monthly bleed, some prefer none. What's vital is that women get the full information of the pros and cons. Now, it is frustrating that research on the pill's long-term effects on things like mood, cancer risk, or metabolism is often conflicting. Now, some known points, the pill slightly increases the risk of breast and cervical cancers, but decreases the risk of ovarian and endometrial cancers. Overall, the cancer risk profile is roughly neutral or even favorable. Some women experience mood changes or lower libido on certain formulations. Importantly, coming off long-term birth control can require patience because after years of suppressed cycles, it can take a few months for natural periods and ovulation to resume regularly. Modern contraception is effective and safe for most, but it's not a one-size-fits-all. Different formulas, combination versus progestin only, pills versus IUD versus implant, have different impacts on hormones. A progestin-only shot that fully suppresses ovulation, for example, will lead to low estrogen, which then might affect bone density or can cause menopausal-like symptoms. Whereas hormonal IUD, the intrauterine device, often lets ovulation continue. For example, many Mirena users still ovulate frequently. And this could lead to a more natural hormone milieu, except localized effects in the uterus. Again, neither is inherently good or bad. What matters is an informed choice. For example, if a 22-year-old woman gets the depot shot annually for 10 years, she should at least be counseled to take calcium and vitamin D and do bone strengthening exercise to counter any possible bone loss. If a woman on the pill reports depression or blunted motivation, a doctor might switch the formulation or suggest a trial off hormones to see if mood improves. Because yes, some studies have linked hormonal contraceptives to increased depression risk in a subset of women. I think overall we can probably conclude that contraception is a boon for women's freedom, but like all medications, it has trade-offs. The narrative shouldn't be fear-mongering like the pill is poison, nor dismissive, that the side effects are rare, just ignore that. The narrative should be, here's how it works, here's what it changes in your body, here are the known risks and benefits, and that we will monitor and adjust to find what's right for you. Empowered choice is the goal. Now, important aspect of women's health is fertility. We often treat fertility and infertility almost like random luck or solely a function of age. Whilst it's true that age is the biggest factor, especially for women, because egg quality and quantity drop significantly after the age 35, an eye-opening truth is that many modifiable factors play into fertility for both women and men. In fact, we did an excellent deep dive into fertility in men and women and diet and how that can contribute in an episode with Ro Huntriss.
Male factor plays a role in up to 50% of cases of infertility. Wow. So, and we've got, all the different sperm parameters, and we actually, we know that sperm quality has decreased dramatically over the past 5-6 decades. And there's lots actually that nutrition and lifestyle can do to improve the status of this. But I do think it's really, really important that there is a growing acknowledgement now of male infertility, which is a really important thing because, as you say, the woman before did carry this big burden, this big stress on her shoulders. And it is a bit of a team effort. And also people think about, the male plays a role in helping the female to get pregnant. But actually, sperm quality, and in particular DNA fragmentation, plays a role in maintaining pregnancy. So high levels of sperm DNA fragmentation are associated with increased risk of miscarriage. So it really doesn't just stop at the point of conception.
So fertility truly is a shared journey and both partners' health matters. We know that being physically active and having good muscle mass is associated with better fertility outcomes. In women, moderate exercise is linked to more regular ovulation and a higher chance of pregnancy. One review found that women who exercised 30 to 60 minutes a day had a significantly lower risk of ovulatory infertility, likely because exercise improves insulin sensitivity, reduces excess fat, which can produce hormone-disrupting inflammatory chemicals, and helps to balance hormones. For men, exercise in moderation can boost testosterone and improve sperm parameters, although excessive training or certain sports like very high mileage cycling or use of anabolic steroids can impair sperm. The key is balance. Extreme exercise, like elite athletes training to exhaustion, can sometimes reduce fertility, causing missed periods, for example, in women. What you eat can also influence your hormonal health and egg and sperm quality. The so-called fertility diet is essentially a well-rounded anti-inflammatory diet, high in antioxidants, omega-3 fatty acids, adequate protein, and low in highly processed foods. There's evidence that adherence to a Mediterranean diet, which is again, just an eating pattern that's rich in vegetables, fruits, whole grains, fish, olive oil, and nuts is associated with improved fertility and higher success rates in IVF as well. In one study, women following an anti-inflammatory Mediterranean-style diet had higher successful pregnancy rates in IVF. Antioxidants from foods help to reduce oxidative stress in the reproductive tract. That's important because developing eggs and sperm are sensitive to oxidative damage. We also need sufficient protein to build hormones, which are made of amino acids, or at least require them to support a healthy uterine lining. On the flip side, diets high in trans fats, processed meats, and sugars can promote insulin resistance and inflammation, which obviously are bad for fertility. Now, to reiterate, it's not about a magical fertility superfood, it's about overall dietary patterns. That said, specific micronutrients like vitamin D and omega-3 fats are often highlighted. Vitamin D helps ovarian function and is linked to better fertility outcomes. More on that a bit later. And omega-3s from fish oil and even flax seeds as well are anti-inflammatory. And both of these have been linked to improved sperm quality in men and potentially better egg quality in women. So in short, food is information for your hormones. Now, moving away from a nutritional perspective, chronic stress and poor sleep can also wreak havoc on fertility. Now, remember, cortisol can disrupt and disturb your reproductive hormone signals. Women under high chronic stress may have more anovulatory cycles or irregular periods. Men under stress can see drops in testosterone and poorer sperm counts. As we said before, stress can cause oxidative stress in the testes, amongst other things as well. There's also a mind-body aspect too. Infertility itself is very stressful and it becomes a vicious cycle. So techniques like mindfulness therapy, moderate exercise, or even acupuncture in some cases can help to break those stress cycles. Specifically sleep. Sleep is when our body repairs, including our eggs and sperm, which carry a heavy oxidative burden. Studies show that women with adequate sleep have more balanced leptin and luteinizing hormone levels, possibly improving ovulatory function. And men who sleep under 6 hours consistently have lower testosterone and higher rates of infertility. So prioritizing good sleep hygiene is not trivial for conception. Now, whilst I'll say that whole food is best, there are certain supplements which could be beneficial. Vitamin D, often called the sunshine vitamin, it's really a hormone precursor. Vitamin D receptors are in the ovaries, uterus, and testicles. Vitamin D deficiency is very common in women with infertility, and one review found it in a large population of patients. Sufficient vitamin D is correlated with better IVF success. One study found that women with over 30 nanograms per mil had 4 times higher odds of pregnancy than those deficient. Vitamin D may also help male fertility. Low vitamin D in men is linked to lower sperm motility. So if you're deficient, supplementation could improve ovarian reserve markers and increase odds of conception. Omega-3s. Now, omega-3 fatty acids, especially DHA and EPA, are anti-inflammatory and are literally building blocks of cell membranes, including the membranes of eggs and sperm. In men, studies have shown that fish oil supplementation users had higher semen volume and sperm count, and randomized controlled trials indicate that omega-3 can reduce sperm DNA fragmentation. In women, omega-3s may improve egg quality and embryo development by reducing inflammatory cytokines on the ovary. Plus, if pregnancy occurs, omega-3s also support a healthy pregnancy. You don't just need to use fish oil, you can use algal oil supplements if you're vegan.
There are other supplements that can be considered, like common ones include coenzyme Q10. So coenzyme Q10 is an antioxidant.
Coenzyme Q10 has gained a lot of attention for women in their 30s and 40s trying to conceive because, based on some of the literature we have, coenzyme Q10 is a potent antioxidant and crucial for mitochondrial energy production and recall as well. And egg cells have more mitochondria than any cell in the body because they need massive energy for early embryo divisions. As women age, egg mitochondria decline in number and function, contributing to poorer egg quality. CoQ10 levels also drop with age. And studies in animals and some early evidence in humans suggest that CoQ10 supplementation could improve egg quality and ovarian function by energizing mitochondria and scavenging free radicals. Many fertility doctors now recommend 200 to 300 milligrams of CoQ10 daily for women over 35, especially if they're trying to conceive or doing IVF. And it's one of the few supplements with promising data for age-related subfertility. Magnesium, this mineral is involved in over 300 enzymatic reactions, including hormone production and utilization. It helps with insulin sensitivity, important for things like PCOS, and muscle relaxation, including the smooth muscle of the uterus. Now, whilst this isn't as directly studied for fertility as some of the supplements above that I've mentioned, magnesium adequacy supports better sleep and stress reduction because magnesium has calming effects. Thereby, you could claim it's indirectly benefiting fertility. There are a few others, folate, for example, for preventing neural tube defects and possibly aiding ovulation in some cases. Vitamin B12 and antioxidants like vitamin C and E, maybe some evidence to support reproductive health. In men, besides omega-3 and CoQ10, supplements like L-carnitine and zinc, again, some emerging but not conclusive data suggest that they could improve sperm parameters in some cases. Now, perhaps the simplest yet overlooked factor is understanding the fertile window. Many women were never taught that you can only conceive in a 5 to 6 day window each cycle, the days leading up to and including ovulation. Apps and ovulation predictor kits can help target intercourse to the right time. And it sounds basic, but some cases of infertility are simply due to mistimed intercourse. Beyond the timing, being aware of one's cycle signs like cervical mucus changes or basal body temperature shifts can actually empower women to know if they're likely ovulating normally or if something's off that might need checking, like very irregular cycles, which could signal an underlying issue to address early. Finally, our modern environment exposes us to various endocrine disruptors. Chemicals in plastics like BPA, phthalates, certain pesticides, all of these things can subtly affect fertility. Whilst it's impossible to avoid them all, being mindful about using glass or steel instead of plastic for storage, avoiding unnecessary chemicals, for example, all of those things can reduce toxic burden on our reproductive systems. Even something as straightforward as heat. Men who frequent hot tubs or keep a laptop on their lap for hours can actually impair sperm production because the testes need to be a few degrees cooler than body temperature for optimal function. Now, unlike some of the fatalistic views you might hear online, fertility isn't just about age and fate. You have more influence than you might think. Now, the flip side is positive. There are things that we can do to enhance fertility by treating our bodies well, nourishing them, moving them, de-stressing, catching problems early. We can set the stage for better fertility outcomes. Doctors now increasingly view infertility not as a standalone disease, but as a barometer of overall health. For example, polycystic ovary syndrome, PCOS, and endometriosis, two very common causes of fertility struggles, are deeply tied to metabolic and inflammatory health.
Endometriosis is a condition where tissue similar to what you bleed every month has found a residence or a home in other parts of your body. And when that tissue finds a home in another place, it's also very hormonally responsive. So it's additionally making its own hormones as well. And it can cause a wide variety of symptoms. And it can also cause infertility. It can destroy vital organs.
If we can address some root causes in our lifestyle through diet, medication potentially, not only can we improve fertility outcomes, but also overall well-being as well. And remember, fertility is a couple's issue. Half of infertility cases involve male factors, so male partners should also sleep well, focus on nutrition, zinc, selenium, vitamin D, antioxidants, all those are key for sperm, maintain a healthy weight, avoid smoking because smoking can damage sperm DNA and lower count. Moderate alcohol. Excess booze can actually drop testosterone and cause erectile issues. And keep those testes cool. Not asking you to dump them in ice buckets, but skip the daily hot sauna. In fact, research shows that men's lifestyles, like smoking, diet, etc., not only affects the chance of pregnancy, but also the future health of the child. And that's via sperm epigenetics. So improving fertility is a team effort and largely about health optimization. Now, in past generations, needing fertility treatment carried a stigma. Some people viewed it as unnatural or a personal failure. And it's time to probably shift that notion. Assisted reproductive technologies like IVF or in vitro fertilization have enabled millions of people to have children that they dreamed of, and there's nothing cheating about it. In fact, IVF has become quite mainstream. As of the mid-2020s, over 10 million babies have been born via IVF worldwide. Some estimates put it at 13 million by 2023. Now, that is a huge number. To put it into perspective, it's like the entire population of a country the size of Greece comprised of IVF kids. So if you know someone who was conceived with medical help, they're far from alone. A related technology is egg freezing or oocyte cryopreservation. This has boomed in the last decade as women realize they can proactively preserve eggs for later. Initially considered experimental, egg freezing is now mainstream for women who want to extend their fertility window, whether because they haven't found the right person, they want to pursue career or education goals, or just need to freeze for medical reasons, like before cancer chemotherapy. Freezing doesn't guarantee a baby down the line, but it does provide an insurance policy of sorts. The best time to freeze is when you're younger, 20s to early 30s, because eggs will be more plentiful and healthier. For example, one analysis found a woman under 35 who freezes 10 eggs roughly has a 60% chance of at least one live birth from those eggs. Whereas the same 10 eggs frozen above the age of 35 might yield only a 30% chance because older eggs are less likely to form healthy embryos. Many women freeze in their mid-30s, which is still quite useful, but earlier is better if one is certain they want to preserve fertility. Again, no shame in it, it's just using technology to counteract the unfortunate timeline mismatch between modern life, where many don't have kids until 30s, and biology. A quick note on IVF success. It's not a guaranteed thing, and success rates vary per cycle and by age as well, from 40 to 50% for young women to under 10% for women in their mid-40s with their own eggs. Many need multiple attempts, but overall, this technology keeps improving. Globally, it's estimated around 2 to 3% of all babies born in developed countries now are via IVF. Now, we've spoken about a lot of aspects of women's health, and one major one we haven't touched on yet, and that's menopause. Menopause has historically been treated as the end of the road, the change after which women just silently suffer through symptoms and fade from relevance. This narrative is not only sad, but it's wrong. For many women, menopause can be a powerful new chapter, free of the monthly cycles and often accompanied by a surge of new energy. But getting through the transition and maintaining long-term health post-menopause requires better support than most women currently receive. Unfortunately, menopause care has been stuck in the shadows of medical education and public discourse for a bit too long. Now, would you believe if I said that most doctors receive only a few hours of training about the menopause in all of medical school, certainly when I was in medical school? A 2019 survey found that 58% of OB/GYN residents had just a single lecture on menopause, and 1 in 5 had zero training on it at all. Only about 20 to 30% of residency programs had formal menopause training until recently, which literally means many new doctors had to learn on the job. This is kind of crazy given that by the year 2030, over 1 billion women worldwide will be postmenopausal, and a doctor can't diagnose or treat something that they don't know. So a lot of women suffering with things like severe hot flashes, night sweats, mood swings, vaginal dryness has been undertreated or mismanaged due to this knowledge gap. Now, this is starting to change, and there's a growing movement to improve menopause education and care, with organizations like the Menopause Society offering courses, but we have a lot of catching up to do. For example, hormone therapy. If you recall, hormone replacement therapy got a really bad rap in the early 2000s after the Women's Health Initiative study reported increased risks of breast cancer, clots, and strokes. Millions of women and their doctors panicked and abandoned HRT overnight. However, deeper analysis over the past 2 decades has shown a more nuanced picture. For example, if HRT is started in the right patients, generally healthy women in their 50s near the onset of menopause, and personalized, i.e. the choice of estrogen, progesterone, type, dose, and route, the benefits often outweigh the risks. Hormone therapy is the most effective treatment for hot flashes and night sweats, improving quality of life dramatically for many. It also helps prevent the rapid bone loss that can occur at menopause, thereby reducing osteoporosis and fracture risk. There's even evidence it can support metabolic health too. Women on HRT tend to have less accumulation of belly fat and better insulin sensitivity than those not. Estrogen plays a role in regulating body fat distribution. Now, the caveat with HRT is that it should be individualized and periodically reevaluated, but the old mantra of shortest time, lowest dose has softened. Now it's more appropriate dose and duration for the individual. Of course, HRT isn't for everyone. Women with a history of breast cancer or blood clots, for example, may be advised against systemic hormones. But even if they have options like low-dose vaginal estrogen for urogenital symptoms, which is super helpful for painful intercourse or urinary issues, and it carries minimal systemic risk. Non-hormone methods also can be useful. Certain antidepressants, gabapentin, etc. can help hot flashes, although usually not as much as estrogen. The key is that menopause is a health span pivot point. The perimenopause years, 35 to 50, are a window to intervene to set a woman up for a healthy next few decades. This means focusing on all the tools, not just hormones, but strength training, nutrition, sleep, and stress management. For instance, by lifting weights and getting enough protein in midlife, a woman can enter menopause with a higher muscle and bone reserve, mitigating the steep decline that estrogen loss causes. By getting cardiovascularly fit, she can counter the rise in heart disease risk that occurs post-menopause. And unfun fact, a woman's risk of heart attack soars after menopause to eventually equal a man's, partly because estrogen had a protective effect on blood vessels.
Often there's well understood factors that predispose women to a worse menopause transition. One of them is having a higher BMI. So this excess adiposity, I should be clear on that. It's not about, if you're really musty, you're in a better position, but this excess adiposity puts you at higher risk of having worse symptoms that are longer and then having worse metabolic health profile as well. What you just touched on is really important for women to realize that post-menopause, they do have a higher risk of cardiovascular disease. Yeah. Cardiovascular disease needs to get more attention anyway, because it's our biggest killer. But often women don't think of it as their problem because it's, men are at higher risk most of their lives, but then we catch up with them after menopause. What we found in our research is that women who had the highest intake of plants, how many whole plants are you having in your diet? That was the best predictor for having a lower symptom severity and number of symptoms, even if you had excess adiposity. So that, to me, that's such a strong signal. Okay, it didn't matter what age you entered menopause, or even if you were taking HRT, you could reduce the number and severity of symptoms if you just had a really high plant diet.
Culturally, we probably need to stop with the idea that women dry up and become irrelevant after menopause, because many women report that their 50s and 60s, once past the initial symptom rollercoaster, are among their happiest years. So menopause is a natural phase, but one that deserves respect and proactive management. With the right approach, women can not only survive menopause, but truly thrive in those years beyond. And it's probably a high time we move past the era of hush-hush and just live with it and into an era of educated, empowered menopause care. So hopefully this deep dive and some of the segments that we've shown from other podcast episodes around women's health and fertility, you can empower yourself with these insights, share them, discuss them with your doctor, and experiment safely with habits, because the payoff could be life-changing. Thanks for listening to the Dr. Karan Explores podcast, and here's to strong women's health and bright days ahead, literally and figuratively. So stay curious, and I will see you munchkins next time.